Hello, everyone. I want to welcome you all to our Metro DC EDS and HSD support group presentation with Dr. Peter Rowe, and Kendra Nielsen-Miles will be introducing Dr. Rowe and moderating the Q&A. So I will turn it over to her. So thank you again for joining us tonight.
Dr. Rowe is a professor of pediatrics at the Johns Hopkins University School of Medicine. He is an inaugural Sunshine National Wellbeing Foundation Professor of Chronic Fatigue and Related Disorders and serves as the Director of Chronic Fatigue Clinic at the Johns Hopkins Children's Center. Oops. His areas of clinical expertise include chronic fatigue syndrome and other disorders characterized by fatigue and orthostatic intolerance. Dr. Rowe and his colleagues were the first to describe the relationship between chronic fatigue syndrome and treatable orthostatic intolerance syndromes, as well as the association between EDS and chronic fatigue syndrome. In addition to his research focus on chronic fatigue syndrome, or CFS, he is interested in the physiologic factors, circulatory dysregulation, allergic disorders, joint laxity, biomechanical strain, and neuroautonomic problems that contribute to chronic fatigue. Welcome, everybody. Thanks for being here.
Great. Well, thank you, Kendra, for that introduction, and thank you, Danielle, for the invitation to speak. It's been a while since I've talked about this. So what I've put together is, I wasn't sure what everybody's level of understanding of these disorders might be. So I've got an overview of orthostatic intolerance, what it is, what the symptoms are, how we diagnose it. Then I want to look at the common forms of orthostatic intolerance, with the emphasis being that orthostatic intolerance is not just POTS, which sometimes is the thing that you'll hear. I want to show some of the new work that's been done on reductions in cerebral blood flow during tilt testing, a little bit on the EDS orthostatic intolerance connection. And then I want to spend a fair bit of time on managing orthostatic intolerance. What are the tools that we have available to us? And then I want to end with a couple of cases that are illustrating some of the new targets of therapy. Those include a variety of forms of venous insufficiency, some neuroanatomic problems like cervical spine stenosis or craniocervical instability, and then the common problem that we're all recognizing with increasing frequency, and that's mast cell activation syndrome. So with that as the overview, let's jump in. Orthostatic is a term that just means upright, and the term orthostatic intolerance refers to a group of clinical conditions in which the symptoms worsen in quiet upright postures, and that can include sitting or standing, and many of those symptoms are improved upon lying down. However, once you provoke fatigue and brain fog, those can persist quite a long time after assuming a recumbent posture. And some of the old data from the 1920s suggests that the fatigue can be present for about 48 hours after something like a reflex faint. The big challenge we face when we move from a supine or lying position to standing is that you get a shift of the usual 5 or 6 liter blood volume. You get 500 to 750 milliliters of that blood moving to the lower half of the body. And this slide from Philip Lowe's textbook on clinical autonomic problems shows that the venous pressure in the legs really goes up substantially. The cartoon is not very good for showing the abdominal circulation because a fair bit of blood pools there as well. So in response to shifting that blood into the lower half of the body, the normal response is about a 10 to 20 beat increase in heart rate and an improvement in the blood vessels of the legs and their ability to constrict. That then shifts the blood back up to the brain. Here's a different way of looking at that from Rowe's book on cardiovascular control. So you get, when you stand up, a bit of a drop in arterial pressure. We have nervous system sensors in the big vessels of the chest and neck. These are called baroreceptors, and they're normally stretched to indicate that there's blood going up to the brain. When they're not being stretched as much, there's an increase in the alarm signal to the cardiovascular control centers in the brainstem. And the end result of that is that you get an increased output of sympathetic nerve activity. That leads to an increase in heart rate, a somewhat of an improvement in the ability of the heart to contract vigorously. And the biggest change comes from the release of norepinephrine from the nerve endings so that it can act on the small vessels of the lower half of the body, improving vessel constriction and then shoving that blood back up to the heart and brain. When that process does not work well, these are the symptoms of orthostatic intolerance. And I'll break that down on the next two slides. One, the symptoms on the left are thought to be due to reductions in brain blood flow. So those include things like lightheadedness, which everybody has experienced, syncope or fainting, diminished concentration that can look like somebody has suddenly acquired attention deficit disorder, headaches that are orthostatic in nature. Blurring of vision is quite common, especially as the lightheadedness is more severe. And then in all forms of orthostatic intolerance that have been described, there's a higher prevalence of both fatigue and intolerance of especially low impact exercise. So our patients with this often do better if they're moving around on the playing field, but much worse if they are standing quietly, like in a museum or in a shopping mall. The symptoms on the right are thought to be due to what's called a hyperadrenergic response to that initial reduction in brain blood flow. The adrenergic response refers to high levels of adrenaline or epinephrine and noradrenaline or norepinephrine. And the hyperadrenergic symptoms can include an orthostatic dyspnea, which is the medical term for shortness of breath. So people start looking like they're having a panic attack, but really this is an attempt to suction blood back up into the chest by taking deep breaths more frequently. Chest pain is particularly common when we have not got good control of the orthostatic intolerance. Palpitations or skipped beats, shakiness, and anxiety are also overrepresented in our patients with orthostatic intolerance, and that's thought to be due to the high levels of catecholamines. The catecholamines are the things like epinephrine and norepinephrine. We can see excessive sweating or hyperhidrosis, nausea, temperature dysregulation. So there are a number of other symptoms. This isn't an exhaustive list, but these are the most common things that we see. When we're asking people about orthostatic intolerance, some people have grown up always feeling lightheaded, and they assume that everybody feels that way. So we want to ask them, first of all, have they ever fainted? And then do they feel lightheaded or unwell when they stand for more than 5 minutes? Some adolescents will say, well, I don't have lightheadedness, but every time I stand up, I get a head rush. Well, to me, that's the same thing. And then we ask very specifically how they feel in individual circumstances like waiting in line or shopping. And my joke to our trainees at Hopkins is that if you've got an adolescent who cannot go to the mall or needs to come home within 5 minutes, you've got an organic problem until proven otherwise. Other common settings for orthostatic intolerance symptoms to be provoked are standing at any kind of cocktail party or reception, in a chorus, in a marching band, at any kind of religious service where there's a lot of standing, and especially after being in a warm environment. So our patients often do poorly in a hot shower, often needing to sit down or lie down for 15 minutes afterwards to recover. They usually don't tolerate a hot tub or a sauna, and they do poorly in the very hot weather in the summer. The other clues that we can get from the history are that many of our patients prefer to study in a reclining position because there's less of an uphill climb to get blood from the heart to the brain. And they will do things that get the blood out of their legs, such as sitting with their knees up to their chest or their feet under them. And many of the patients who have orthostatic intolerance don't realize why, but they fidget a lot when they're standing, and that's using their leg muscles as a pump to get the blood back up to the heart. For diagnostic testing, it's really important that we as physicians and other healthcare providers don't just have people stand for 1 or 2 minutes. The orthostatic vital signs, where you look at heart rate and blood pressure, supine, sitting, and standing, when that's done over a short period of time, it's really insufficient to identify the common forms of chronic orthostatic intolerance, and we usually need prolonged testing of at least 10 minutes. The kinds of tests that are available include standing tests, and that's usually for about 10 minutes after we use 5 minutes supine. We use the passive standing test, where people are leaning with their shoulders back against the wall with the feet 6 inches or so away from the base of the wall. The active standing test just has the patient standing in the middle of the room with the blood pressure cuff on. We do 5 minutes supine, taking a blood pressure and a heart rate every minute, and then we stand them for 10, occasionally more than that, minutes with the feet, as I mentioned, leaning against the wall, and we measure the heart rate and the blood pressure each minute, and we record the symptoms every 1 to 2 minutes. And this is a variation of a test that was first published back in 1975. For head-up tilt testing, this is a motorized table that is brought up to usually a 70-degree position after about 15 minutes supine, and the person remains upright for 45 minutes unless symptoms get really severe or they get to the point of near fainting or fainting. Some facilities will do a second stage of the tilt test, where if you've tolerated that first 45 minutes upright, they bring the table down and they start an adrenaline-like material called isoproterenol that increases heart rate by about 20%. And that then the table is brought back up to the 70-degree point for 15 minutes. So what are the types of orthostatic intolerance that we see? One of them that's important to recognize and has received more attention because many people after COVID are developing initial orthostatic hypotension. This refers to a transient drop, really quite substantial, of 40 millimeters of mercury of systolic blood pressure or 20 diastolic within the first 15 seconds of standing, and it usually lasts less than 60 seconds. So these are people who only get picked up if you've got a beat-to-beat blood pressure measuring device. So, for example, if you do a blood pressure 1 or 2 minutes after the tilt table goes up, these patients might be normal. This is a very common phenomenon in adolescents, but again, unless you've got beat-to-beat blood pressure measuring, you can't really pick it up. We don't necessarily need to treat it if patients are not having a chronic impairment in their function, but the best way of treating it and preventing the dizziness and wooziness upon standing is to have people really clench their buttocks and leg muscles as they stand. Second type of orthostatic intolerance is orthostatic hypotension, where you get a sustained drop of 20 millimeters systolic or 10 diastolic, and this has to occur within the first 3 minutes of standing or head-up tilt testing. It's much more common in older adults who have something else wrong with their autonomic nervous system, like Parkinson's disease or diabetes, but we will see it in adolescents and young people of any age, actually, who are volume depleted from a gastrointestinal illness, and occasionally from people who have anorexia nervosa, where they can also get orthostatic hypotension. Delayed orthostatic hypotension refers to the same drops in blood pressure, but it occurs after the 3-minute point upright. Then we come to postural tachycardia syndrome. This requires a 40-beat increase in the heart rate between the supine and the standing values in adolescents, so anyone under 20. And once you hit 20, it requires only a 30-beat change. This has to be in the first 10 minutes of standing or tilt testing. And it isn't just the heart rate change. The person usually has to have chronic orthostatic intolerance symptoms. And if they have orthostatic hypotension in the first 3 minutes, that becomes the diagnosis, not POTS. Neurally mediated hypotension is a reflex form of hypotension where you get a fairly substantial drop in blood pressure, usually associated at the time the blood pressure drops with a reduction in heart rate. We're also recognizing more frequently over time that many people have an inappropriate sinus tachycardia. So that refers to a sinus rhythm. So it's not a rhythm disturbance. It's just that their heart rate is beating at a rate of over 100 at rest. And the symptoms are often similar to those of people with POTS, and they can have both inappropriate sinus tachycardia and a 30 or 40 beat increase during standing that would be consistent with POTS. And we'll come back to this, but I also want you to know that we really have to pay attention to the symptoms, because orthostatic symptoms can be quite profound and associated with reductions in brain blood flow, even if you don't demonstrate a tachycardic response or a drop in blood pressure. So it's important for us as healthcare providers to really listen to what the patients are reporting. These are some diagrams of the two more common forms of orthostatic intolerance. So on the left, you see a standing test. This person has a pretty normal resting heart rate in black. As soon as they stand up, they start getting lightheaded, they get tired, they get a headache, and the heart rate has gone up a total of 51 beats between the lowest supine and the peak standing. This is usually a sustained elevation in heart rate with POTS. On the right, you see somebody with neurally mediated or vasovagal hypotension. And here's a person who has a normal resting heart rate. It goes up 9 beats with tilt testing to 70 degrees. This individual was immediately lightheaded and pale. And then at the 5-minute point, you can see that the blood pressure completely bottoms out. And with that, there's a reduction in heart rate that's quite classic for this phenomenon. The reduction in brain blood flow was abrupt enough that the person had seizure movements, but this is not a seizure disorder. This is just because of the sudden withdrawal of blood and oxygen from the brain, and the presence of seizures during the tilt test has no real prognostic value. You just treat the hypotension like you normally would. Again, just to counter the comment that you'll sometimes hear that POTS is the only form of orthostatic intolerance, we think that we know that they can occur together, both POTS and neurally mediated hypotension. So here's somebody whose heart rate goes up 44 beats per minute in the first 10 minutes upright, and they can maintain their blood pressure for a while, but eventually at the 20-minute point, you see that blood pressure again plummets in association with a marked reduction in heart rate that is classic for this vasovagal or neurally mediated response. Another thing we look for is acrocyanosis, which refers to this kind of purple discoloration of the dependent limbs. So this is a young woman who had to stop attending Kenyon College because of the severity of her fatigue and lightheadedness. This is a young woman who had EDS that had not been diagnosed at that point. And here's her hand on the left after about 5 minutes of the passive standing test. And that's my hand as a background color comparison. On the right, I've done what we call a capillary refill test, where we press on the skin and cause it to blanch. And then we expect blood flow to fill up those spots within 3 seconds. So I pressed my fingers on this girl's leg. I stepped back, found my phone, found the camera icon, turned it on, focused the picture. And this was her lack of capillary refill 7 or 8 seconds after we'd pressed on her skin. So this is quite striking when it's present. We looked back at our data and wondered, do you really have to continue people upright for 10 minutes? Wouldn't the most severely affected patients be obvious within 2 or 3 minutes? Well, it turns out that after about 3 minutes, you've got somewhere around 40% that you would miss who develop POTS over the first 10 minutes. You might wonder, well, are the ones who get it earliest the most severely affected? And there's actually no difference in their overall severity of symptoms or their overall health-related quality of life, whether they tested positive at 9 minutes or at 2 minutes. So you really need the full 10 minutes if you're going to make an attempt to diagnose POTS. This slide shows the main factors that go into the physiology of developing orthostatic intolerance. We know that patients have an increased pooling of blood when they stand, possibly due to some sort of defect in their ability of the vessels to constrict and send the blood back up. In formal research studies, and most people have not had this done at a clinical level, but where you can do a measurement of blood volume, people with orthostatic intolerance usually have about a 10 to 15% reduction in what you would expect them to have based on their height and weight. Those blood volume tests are quite expensive. They're $3,000 or $4,000, and so they're not covered by insurance, and that's why probably nobody in the audience has had that done. But the combination of this shift of blood and the reduction in intravascular volume, when you then stand or on a tilt test, you get a big reduction in brain blood flow, and that elicits a big sympathoadrenal response. And the end phenotype of this can be a heart rate or blood pressure defined syndrome of orthostatic hypotension, delayed orthostatic hypertension, the NMH and POTS, or you can have low orthostatic intolerance where you have a normal heart rate and blood pressure. Let's look at some of the new work that's been emerging on measuring cerebral blood flow. So the question that comes up often is, what does it mean if you have a lot of symptoms with standing, but the formal tests of heart rate and blood pressure are normal during a standing test or head-up tilt test? Does this mean that nothing is wrong? And the answer is emphatically no. This is some really novel and innovative work by colleagues of ours in the Netherlands, Linda van Kampen and her husband, Frans Visser. They came up with the idea of measuring brain blood flow more directly than we had been able to before. Some of you have heard about transcranial Doppler or TCD testing. This is a very finicky test that doesn't really reflect true blood flow to the brain. It picks up blood flow velocity through one of the vessels, but we found that it's not really very sensitive to identifying the total reductions in brain blood flow. So what Visser and Van Kampen came up with is a technique where they put their ultrasound probe on each of the 4 vessels that are bringing blood flow to the brain. Takes about 30 seconds to acquire the images from each internal carotid and each vertebral artery. But adding the flow through those 4 vessels, you get total cerebral blood inflow. So they looked at a huge group of their patients using this technique. And you don't really have to be an ultrasonographer to see the difference between the flow through one of the vessels when they're lying down, and you can see a big reduction in flow volume when the person is standing. So they studied the largest group ever compiled of patients with chronic fatigue syndrome, ME/CFS as it's now known. They had 429 adults with this and 44 controls. And what they found was that they couldn't, with this technique, capture the ones who had that sudden drop in blood pressure. There weren't very many of them in their study, but they found that 28% met criteria for POTS, 14% had the delayed orthostatic hypotension, but 58% had a normal heart rate and blood pressure and probably were at risk in the usual setting of being told, there's nothing wrong with you, see you later. Well, when they put together their data, after 30 minutes on their head-up tilt test, the healthy controls would get a 7% reduction in brain blood volume compared to their supine values after they'd been up for 30 minutes. When you took all of the chronic fatigue syndrome patients together, they had a 26% reduction. So almost a 4-fold greater reduction of brain blood flow than the healthy people. And when they broke that 26% down, the ones who had POTS or delayed orthostatic hypotension had greater reductions. But the group that you might have thought was normal because they didn't have a heart rate or blood pressure change, nonetheless had a 24% reduction in brain blood volume. So I think it's no wonder that they were lightheaded, tired, couldn't think well, and had other symptoms. Overall, 90% of their adults with ME/CFS had a significant reduction in brain blood flow using this test. So why does this matter with EDS? what's the connection here? Well, we had first noticed that we had a couple of patients in our chronic fatigue syndrome clinic, adolescents, who had the diagnosis of Ehlers-Danlos syndrome. And I thought, well, let's see how common this really is. So of the next 100 adolescents, we looked at them carefully with a Beighton score, looked for other features of EDS like skin striae and other factors. We had them all seen by Irene Momini, who was the chief genetic ophthalmologist at Hopkins. And we looked at them with Michael Garrity, who's a geneticist. He confirmed all of these diagnoses. And over a 1-year period, we had 12 out of that 100 who had EDS. So 6 of them had the classical type, 6 had the hypermobile type. Most were female, and all of them had chronic orthostatic symptoms, either with NMH alone, POTS alone, or some combination of the two. And all of them had an increase in their typical symptoms when they were upright. The reason this was important, we think, is that up until that point, most of the monographs on EDS used to say, you know, if you have the diagnosis, you're going to have fatigue and widespread pain, and there's nothing you can do about it because it's a part of the genetic syndrome. What we said was, well, orthostatic intolerance is a treatable problem, and it gives us a toehold into treating the general symptoms, including the fatigue. That work has now been confirmed by a number of other groups, none more elegantly, in my view, by Inge de Vondelay, who's a physical therapist in Belgium. She had a large study where they had 80 people with the hypermobile form of EDS, and 94% of them reported symptoms of orthostatic intolerance. They had them fill out a long autonomic symptom profile, and their total score was much higher than the controls. They were much more likely to have objective orthostatic intolerance, again, just measuring blood pressure and heart rate. They did not have brain blood flow measures, but so that they may have underestimated the proportion who had true reductions in brain blood flow, but it was still a very significant difference compared to the healthy individuals. And in their study, POTS was the most common form of orthostatic intolerance that they identified. This is a slide from one of Inge's papers showing that when you compare the hypermobile to the classical type of EDS, they both have a fair amount of orthostatic intolerance, but the hypermobile folks are much more likely to have problems in the gastrointestinal tract, with sweating, with irritable bowel type symptoms, and so on. But comparing hypermobile type to the healthy individuals, it's really quite a striking difference. When we summarized the literature a couple of years ago, with one of our summer students, Maria Roma, who has EDS, along with Dr. de Vondelay and Dr. Francomano, we found that there were no population-based studies. So you really couldn't tell what's the prevalence of orthostatic intolerance in all people with EDS. But in the papers that have been published, there was a wide range of orthostatic symptoms on a regular basis, 41 to 100%. And with testing, heart rate and blood pressure abnormalities were identified in between 56 and 80% of the people with either joint hypermobility or EDS. And a lot of the higher rates of abnormalities were identified in the studies that had more intensive testing, as you might imagine. Back to Visser and Van Kampen, they decided to look at their large database. By this point, they had about 1,000 patients, and they decided to compare the ones who were hypermobile with the ones who were not. And they had a pretty strict definition of hypermobility. They needed people to have either a diagnosis of EDS or a Beighton score of 6 or higher. And so they compared the cerebral blood flow reductions with tilt testing, and the ones who are hypermobile were more likely to have an even greater reduction, 32%, compared to the non-hypermobile people. And this didn't matter if they had POTS or a normal heart rate or blood pressure. So that this makes it look like the ones who have hypermobility have increased laxity in their blood vessels, so that when they get that pooling of blood into the lower legs and the venous pressure is distending the vessels, they can dump even more blood into the legs than you would if you were otherwise not affected by EDS. So I want to spend a fair bit of time on how we manage this disorder. We begin with non-pharmacologic measures. We then move on to treat contributory conditions. And I think this is a critical step that is not emphasized enough by people whose main training is in cardiology or neurology. As a generalist physician, I want to look for all of the things that can influence the orthostatic intolerance, but might not be cardiac in origin. Then we move on fairly quickly to treatment with medications, and that begins with single drugs, monotherapy. But we often have to move to what I call rational polytherapy, using drugs that will tackle different parts of the physiology, different aspects, different mechanisms. One of the older non-pharmacologic measures that was published back in 1944 was to raise the head of the bed. This has an effect of causing the kidneys to produce less urine overnight. So that preserves your blood volume, and you awaken with a better blood volume than you might if you were losing a lot of blood volume into the urinary system. Notice this guy has the whole frame of the bed is up on these hospital chairs, and he's got a little speed bump to make sure he doesn't slide out of the bed. We've found that this effect can be obtained just by putting 2 red bricks under the headboard of the bed. So about a 10 to 15 degree angle, not like a 20 degree angle that you see here. And the work from 1944 was replicated by a Dutch group in the early 1990s. So this is a tried and tested method. Not everybody tolerates it, but it's awfully simple to do. We recommend compression garments, and we find that the support hose that go to the waist are better than the ones that go to the top of the thigh, and those are better in turn than the ones that are knee high. So the area that you cover with these compression garments matters. We find also, especially for our EDS patients, that the 20 to 30 millimeter mercury stockings are better tolerated than the 30 to 40 ones. The 30 to 40 millimeter mercury compression is better compression, but it requires some help to get these things on and off, and can be a bit of a strain on people with EDS if their hands and finger joints are also quite lax. So the 20 to 30 is a compromise. People find that the body shaper garments, like you see in the middle panel, this is a Spanx garment that goes from the top of the abdomen to the lower thigh. Those can compress an area that has a lot of blood pooling. And abdominal binders are an even cheaper version of abdominal compression that you can get for about $10 or $15. Another thing that many patients already know but don't know why they're doing is they use postural countermeasures that are designed to use the leg muscles as a way of pumping blood that is sitting in those vessels and not being pumped back up to the heart and brain. So the classic stance is to stand like this young woman on the right is doing, with your legs crossed. She also gets a little bit of calf muscle engagement because she's wearing boots with a little bit of a heel that engage the calf muscles better. Sitting with the knees to the chest or leaning forward in a chair when you're sitting, elevating the knees on a little camping stool so that the hips are higher than the knees will help improve blood pressure. And there have been some papers on clenching the fists right before standing up, but this we don't encourage this in school children because it can look like they're about to start a fight. It doesn't add all that much, but these postural countermaneuvers can be quite helpful. These are some of our patients with the way they sit, and I'll draw your attention to the girl in the upper right panel who has her left leg up on the car seat while she's driving, a very common position for our patients. In terms of fluids, we want people drinking at least 2 liters a day if they're adolescents and adults. And this fluid has to be distributed throughout the day. So we don't want people guzzling just after school so they don't have to use the school bathroom. They need access to fluids at school and at work. We want to make sure that if people are quite somnolent and sleeping 16 or 18 hours a day, that somebody awakens them after 12 hours, gets them hydrated, gets them up and moving around a bit. They might have to go back to bed later to nap, but if they sleep for a solid 16 to 18 hours, they are going to awaken dehydrated, trigger these reflex interactions, and increase the fatigue. Cooling garments might be helpful in the hot weather. Salt can be increased according to taste, and in the old paper using that raising of the head of the bed, they used up to 16 grams of sodium per day. But usually that's not something that people tolerate based on taste these days, but some people need up to 10 grams of salt daily. And if they don't like the taste of salt, you can supplement this with a variety of different types of salt tablets or oral rehydration solutions. Some of the cooling garments that people tolerate to help with the tolerance of the heat are these neck wraps and cooling beanies. The vests that you see in the bottom right are about $250 to $300, and they usually draw a fair amount of attention to the person because they're in bright fluorescent colors, orange and green and pink. But if people have to be outdoors in the heat, these are a good way of helping to tolerate that. And because multiple sclerosis patients also have a lot of heat intolerance, you can find a fair number of these devices on the MS cooling site, including this kind of beanie. These are some of the oral rehydration products that are out there. There are really more and more of these all the time. Tri-Oral is a packet that you can add to water. This has the World Health Organization type of recipe for oral rehydration solutions. Cerebral was developed by some people at the Hopkins School of Public Health. And a lot of our patients like liquid IV packets, which can be added to water. In terms of activity and exercise, we want people to avoid too much bed rest and sleeping, and we want them to be upright if possible for a good part of the day. But for many people who are really impaired, you've got to start activity slowly and increase gradually, aiming to avoid provoking what's called post-exertion malaise, where you go through an activity and then you have at least 24 hours of worse function. Recumbent activities may help at the outset, and we're very much opposed to a rigid advancement of graded exercise. We also find, as I'll show you later, that exercise is not always tolerated until you've treated the orthostatic intolerance more effectively. We find that using manual forms of physical therapy can be a bridge to better tolerance of exercise, in addition, especially in people with EDS, to helping with myofascial tightness or muscles being tight and helping with their alignment. Among the treatable conditions that we look for are these shown on this slide. One, obviously, is the overlap with ME/CFS. Depression can be a consequence of feeling so lousy with your orthostatic intolerance and EDS, so we feel that needs to be recognized and treated when it's present. Anxiety is overrepresented in those with orthostatic intolerance, and there are some papers on the increase in anxiety with EDS, maybe because of this. We see a number of motility disorders in the bowel in people with EDS. 30% of our patients with chronic fatigue syndrome have a milk protein intolerance, and that's heralded by symptoms of upper abdominal or epigastric pain, reflux, and a sense of feeling full soon after starting to eat. And it's a delayed reaction, usually to milk protein, but it can occur to soy or wheat or other foods. But the patients who have that don't always recognize that milk is a problem for them. But if they have those main three symptoms, we will try them off milk protein, and often they feel much better in terms of their GI symptoms and also in terms of their fatigue. Mast cell activation syndrome wasn't recognized until about 10 years ago, but we're finding that it's more common in people with EDS, so a hunt for that will be important. I'll show you some of that information later. We want to treat inhalant allergies and asthma when they're present. Anybody with orthostatic intolerance tends to have a worse time after a new viral infection. They tend to have a slower recovery. And even though it may seem paradoxical, many patients with EDS can have focal areas of restricted range of motion that are best identified by skilled physical therapists. Another thing that we've been looking for and is a focus of a current study that we're doing is symptoms of thoracic outlet syndrome, where people with their arms overhead will get all kinds of arm fatigue and numbness and tingling, but also systemic fatigue and circulatory changes. And thoracic outlet syndrome also seems more common in those with EDS. Migraines and chronic daily headaches are contributors to orthostatic intolerance. And there's a subset of patients that have either Chiari malformation, which is a little bit more common in people with EDS, some form of instability of the ligaments at the skull base that's termed either atlantoaxial instability or craniocervical instability. And we have some patients who have single or two-level disc bulges causing cervical spinal narrowing or stenosis. And in our patients with EDS, we see more problems with pelvic vein incompetence, which is where there are varicose veins in the pelvis. And I'll show you some of this in a bit, but we know that earlier onset of varicose veins is more common in people with EDS. It's easier to see those if they're varicose veins in the legs. The ones within the pelvis are not really visible most of the time. And then, as I'll also show you a bit later, we're finding that a number of other vascular malformations, including median arcuate ligament syndrome, which gives you epigastric pain after eating or drinking, and this can be severe enough to cause quite impressive weight loss. MALS is also something that's being recognized more frequently of late and seems more common in people with connective tissue laxity. So on to the medications, and we'll spend a bit of time on these. If you remember back to the diagram I showed you about physiology, we have problems with poor vasoconstriction. Well, we can treat that with vasoconstrictor medicines, the common ones being midodrine and the stimulants. The SSRI and SNRI antidepressants have some mild effect on vasoconstriction. And droxidopa is another one that's used, typically not easily obtained from insurance companies, but it's available for older adults with orthostatic hypotension. To treat the reduction in blood volume, we try to increase blood volume with sodium, which draws fluid into the blood vessels. Fludrocortisone or Florinef is another drug that does this. In girls, birth control pills can help. And we use clonidine, which is originally it was introduced as an antihypertensive drug, but has an effect on expanding blood volume in people with low orthostatic tolerance. Desmopressin is something we use to help reduce the amount of urine formation overnight so that people awaken in the morning with better blood volume. And then if there is too much of a catecholamine effect driving up the heart rate, we try to block that with beta blocker drugs. Another new one that's been available in the last few years is ivabradine or Corlinor, which controls heart rate without affecting blood pressure. And then we use a lot of pyridostigmine bromide as another way of balancing the autonomic nervous system tone. So with all that many medications, how do you select your initial therapy? Well, some people have recommended an algorithm approach, and we prefer an individualized approach, but nobody has studied these head to head. So you're really going on the experience of individual clinicians. This is an example of an algorithmic approach from the Mayo Clinic folks. They want people to be well hydrated. They specify a certain salt intake, support stockings, education, and activity. And then for them, a beta blocker is the first line therapy for their patients who have POTS. Midodrine, which is an alpha agonist, is the second line therapy. And whichever one of these you started with, you'd use the other one as your second line. Then they go to Florinef, then they go to the antidepressants, and they use the others infrequently. We find that we've got more data available to us. So if we see that the resting blood pressure is fairly low, and for adolescents, it would have to be around 90 or lower, and for adults, 100 to 110 or lower, When blood pressure is that low at baseline, adding a beta blocker might be a way of making people feel worse. It's not totally contraindicated, but in that setting, we'd rather use fludrocortisone to build up blood volume or midodrine. On the other hand, if they have an increased heart rate at rest, let's say 90 beats per minute in an adult, you could use a beta blocker. If they're over 100, that is, if they have inappropriate sinus tachycardia, ivabradine can be very helpful in that setting. And there's now a randomized trial showing that ivabradine works very nicely in people with POTS. But you can look at other clinical clues. We once had a boy who kept a salt shaker on his bedstand, and he would pour the salt onto his hand and lick it. He was going to get fludrocortisone as a way of conserving his sodium in the bloodstream. If you have headaches, beta blockers can be good for both the orthostatic intolerance and the headache prevention. In young women, if they have bad menstrual cramping or really bad fatigue with their menstrual periods, we will start a birth control pill, often giving them a continuous active pill so that they don't have a period for they only have one period every 3 months. If there is comorbid anxiety or low mood, that's where you might want to pick one of the anti-anxiety, antidepressant drugs first. If people have a lot of aches and pains, one of the SNRI antidepressants, Cymbalta or duloxetine, can be helpful for that because it's been proven in randomized trials to be effective in people with fibromyalgia. We find in our hypermobile patients, because we think their vessels being too stretchy are the main problem with orthostatic intolerance, we want to give them something that makes those vessels constrict. So those are the stimulants and midodrine, much more commonly in that population. So the summary comments are that the management of orthostatic intolerance really requires a lot of attention by the patient and the practitioner to the factors that provoke their symptoms. People really need to be willing to try several medications before they find a good fit. And it requires a realization that the medicines can often treat symptoms, but don't necessarily cure the orthostatic intolerance. And we really need to be on the lookout for all of the other comorbid conditions that can influence this. This is not just the cardiovascular problem. So I've added some references to some of the papers that you might want to look at. And these are the references, and Kendra and Danielle will have the slides after this talk, so you can look these up later. These are some of the references on the overlap of orthostatic intolerance and EDS. There are a number of really good web resources. The Solve MECFS initiative is the main patient advocacy group for that illness. They often have webinars and talks. If you want a more detailed description of some of the medicines for orthostatic intolerance, I did a talk on YouTube that's available if you search under Dr. Peter Rowe. The joke is that if you just type in the name without the doctor, you get the guy who is the director of the old movie, The Little Shop of Horrors, which some of my colleagues think my clinic should be called. Dysautonomia International has some talks available. They have a pretty good summer conference each year, and you guys know about the EDS Society, and there's some other EDS groups that have very good webinars and things out there. Let's move on then to a couple of cases that emphasize new targets of therapy. I'm going to skip the first one because that one isn't really new, and start with this medical student who came in. She was a student at Hopkins in her first year, and she started getting persistent fatigue, unrefreshing sleep. She couldn't exercise. She had lots of muscle aches, and she had a lot of problems with thinking and concentrating. She'd been absolutely fine beforehand in terms of daily function, but she had a history of having started fainting once or twice a year since the age of 11, usually when she was standing or after a hot shower. And what might have been a clue that she had a connective tissue problem was that she had frequent knee dislocations, and she'd had 4 spontaneous pneumothoraces, where you get air building up between the chest wall and the lungs. In medical school, mainly because she was sitting all day long listening to lectures, she was much more lightheaded, and she was getting a couple of episodes of near fainting each week instead of each year. And she was lightheaded several times a day. If she would faint, she'd have worse fatigue for many hours after doing so. And when people thought she had atypical depression, and tried her on sertraline or Zoloft, she had even worse function. So that even though we often use Zoloft in this setting, it can make matters worse. And in the end, she had to repeat her first year of medical school, which was a tough pill to swallow. She had acrocyanosis of the limbs, like we showed you earlier. And it was her tilt test that I showed earlier, where she got to the 5-minute point and her blood pressure plummeted. Our staff in the tilt table room noticed that she had a lot of joint laxity and that her skin was pretty stretchy. And fortunately for her, the echo showed that she had a normal aortic root and did not have Marfan syndrome. So the diagnosis by our geneticists was Ehlers-Danlos syndrome. So we treated her, again, thinking that her vessels were stretchy. We wanted to improve her vasoconstriction with midodrine, and that with salt and fluids made her have a resolution of the syncope. So she was able to progress through medical school. She came back about a year or two later and said, you know, I'm really worried about my ability to tolerate standing during surgical training because I get pelvic heaviness and low back pain whenever I'm upright for any length of time. So she had this thing called pelvic congestion syndrome or pelvic venous insufficiency, where you get worse pain in the pelvis and low back the longer you're upright. So this tends to be worse at the end of the day. It's also a bit worse with the menstrual cycle, but it's present daily. It's not just when you're having the menstrual bleeding. The other symptoms that have been described over the years are that these women have fatigue, they have very painful intercourse, and bladder urgency. And the fact that they're having pain with intercourse led to some back in the 1940s suggesting they were emotionally frigid. But it turned out that this syndrome is strongly associated with varicose veins in the pelvis. Usually the ovarian vein and the internal iliac veins are all stretched and dilated. And when you do a catheter-based treatment, women will have 90% or so will have an almost complete improvement after embolizing these varicoses. And let me show you what that looks like. So here's the pre-embolization catheter coming up through the right groin over into the left renal vein and down into the ovarian vein. And then with insertion of contrast, you should see one vessel going down to the ovary. This young woman had multiple tangles of vessels, and the contrast should not cross the midline of the uterus, but you see it's already crossed over and there are varicoses on the other side. The interventional radiologists then insert these little things that look almost like a pipe cleaner, a wire with some cotton on it and some chemicals to cause those veins to scar down. And here's the post-embolization picture with the blood, with the contrast only in the ureters going down to the bladder. So what happened to this young woman? She had improvement in her pelvic pain and her orthostatic symptoms after this procedure. And she was able to stand for 7 hours during her surgical clerkship. And she said she wanted to be a surgeon. And our joke, depending on your perspective, was that we still had to work on her cognitive symptoms, or that maybe they'd improved a lot. One thing that has emerged more recently, and this was a paper at the top by Dr. Newton, is that we can also see a different form of problem that leads to some of the pelvic congestion syndrome, and that's when the right iliac artery, as you're going from the aorta to the iliac artery and the blood to the legs, the artery is a thick-walled vessel that sits on top of a thin-walled vein. So this is the left common iliac vein, and it can compress that vein, especially if people are in bed a lot. And so the patients who have this syndrome, May-Thurner, often benefit from having this vein underneath stented so that it's no longer compressed. Occasionally, you'll see left leg swelling in this situation. And we've had a number of young women who've needed stenting. And with stenting, they often report improvement in their orthostatic symptoms because the blood flow is getting back to the heart. They even have improvement in things like migraine, in their bladder urgency, and so on. So it's important to have a high index of suspicion for these venous abnormalities. Here on the bottom is a paper from a German group. Skolbach is a major investigator in these different types of venous and arterial compression syndromes. And he feels that these are much more common in people with hypermobility. And the picture on the left here is a slide showing that here there's a ligamentous narrowing of the celiac artery, causing the median arcuate ligament syndrome, where you get compression not only of the celiac artery, but of the many nerves that are in the celiac plexus of nerves that when you treat this surgically and relieve the compression of this area, many, but not all patients, many patients have improvements in their postprandial abdominal pain. I want to mention another problem that we see. This was a 20-year-old I was asked to see who had recurrent fainting. We thought she might have a connective tissue problem because she started having shoulder dislocations playing volleyball at age 10. At age 18, she started having multiple episodes of fainting. And what was unusual about her was she had no prodromal lightheadedness or warning that she was going to faint. She just went down like a stone. And afterwards, she'd be incredibly fatigued, but also because she couldn't protect herself going down, she'd had 19 concussions. She was treated with a number of medicines that we all use for recurrent syncope, but nothing was working. We saw when we examined her that she had a number of widened scars at the site of her shoulder surgery. She had stretch marks on the thighs. She had the pisogenic papules of the heels that we see with EDS. Her Beighton score was elevated. She had blue sclera, and she had quite brisk reflexes. So we obtained an MRI, and here she is having fainted on our watch in the hospital when she stood up and got a terrible black eye with it. What we saw on the MRI is she had this blackish area here, which was a pannus formation right behind the odontoid at the skull base. And this was right up against her brainstem. And it made us wonder, well, what happens when she bends her head forward? And so we went back and asked her, what are you doing when you lose consciousness? And she said, well, usually I'm splashing water in my face above the sink first thing in the morning. And then her face would smash down against the porcelain of the sink or the toilet next to it. And you can get a sense that when she does flex her head forward, this area is being strained. So we sent her to Dr. Henderson. He thought, well, let's manage her just with a cervical collar. And she did very well without fainting until she would take the collar off and then forget how to position her head so that she wasn't bending forward. And she had 2 more concussions over the next year. We thought she's at risk for chronic traumatic encephalopathy, like the football players who get recurrent concussions. And so Dr. Henderson fused her at C1 and C2. She's now about 6 years out from surgery with no further concussions or syncopal episodes. So this is another kind of thing to keep in mind, that people with EDS are more likely to develop. Dr. Henderson and a number of us have contributed, have done some analyses on a consecutive series of EDS patients that he and his colleagues treated. And here is the pre-surgery frequency of syncope or pre-syncope. Several of the patients had daily or multiple times per week, or at least weekly fainting or near fainting. And you can see that after surgery in blue, that number is substantially reduced. We've also written about cervical spinal narrowing. And here's a young woman who'd had 6 years of POTS and chronic fatigue syndrome and finally had some abnormalities on the neurologic examination that made us get an MRI. And what you should see here is lots of fluid, white spinal fluid on either side of the spinal cord. But in her case, this whole area was narrowed. Normal diameter from front to back is 13 millimeters in the cervical spine. Anything less than 10 counts as cervical spinal stenosis or narrowing. And she had a disc bulge here at the C6-7 that was pressing on the spinal cord. When she had that disc replaced by a spine surgeon, she had complete resolution of her POTS, her fatigue, her cognitive problems, and interestingly, this free-floating anxiety that had also accompanied her problems. We then referred two other patients to Dr. Edwards, the spine surgeon. This young woman had 2 areas of disc bulge in the cervical spine. She'd been sick for 7 or 8 years, had very brisk reflexes that had been blamed on her psychiatric diagnoses for some reason, but you can see that the spinal cord is thinned out in this area where the disc bulges are present. Here's the cross-sectional view up around here where she's got lots of spinal fluid around the spinal cord. Here you see the black area, which is her disc pressing asymmetrically on the spinal cord, and she also had cervical narrowing. This patient had been out of work for 5 years by the time we saw her, and she's got a huge disc bulge here that you can see is causing asymmetric compression of the spinal cord. And she did so much better after her disc replacement that she was able to go skiing at WISP 3 months after the surgery, even though she'd been housebound for several years beforehand. So it's very important to do a careful neurologic examination. This is just the improvement in the heart rate increment when they stood between pre-op and post-op, their physical function scores, and their general global function using the Karnofsky score. So this is something to be aware of. Clearly not a factor for everybody, but worth thinking about in the people who are not improving by any of the typical medical management techniques. Lastly, I want to tell you about this young woman who developed CMV at 14, and by the time I saw her a couple of years later, others had diagnosed her with orthostatic intolerance. She had joint hypermobility, hypothyroidism, but treating that didn't make her any better. She had some mild depression emerging, migraines. She was a bit tight on the physical therapist's exam. And she finished high school. She went to college at the University of Maryland. Nothing we found for her headaches really worked very well. She did a bit better with salt and fluids, but none of our standard orthostatic medicines worked very well. By the time she was 22, she had a resting heart rate that was quite elevated at between 104 and 140. And then anytime she tried to get on the elliptical machine, within 2 minutes, her heart rate would spike up to 180, and she would provoke a couple of days of migraine headache. And we had to say to her, look, stop exercising like that. You're making yourself worse. Let us get your circulation under better control. The other thing that had happened was she had some allergies and asthma, but well into the illness, she started getting hives after the intake of things that she tolerated before, like watermelon. She'd get belly pain after eating apples and bananas. She got hives on her hands using hand sanitizers, and she had to wash her clothing twice, once with detergent and once to rinse out the detergent. So you guys know what's going on here. She had inappropriate sinus tachycardia with a heart rate that high, and she had mast cell activation syndrome. So mast cells can dump out all kinds of things that contribute to fatigue and to these cardiovascular problems, especially histamine. And I've put in here some information that you guys may already know about. These are papers by Larry Afrin, who's one of the leading thinkers about mast cell activation, especially in the setting of long COVID. Anyway, we treated her with ranitidine because it was on the market back then, and that helped her sinus congestion. Montelukast or Singulair, which is a mast cell membrane stabilizer, helped her migraines. Quercetin, which does something similar, helped her overall energy, but her heart rate was still elevated. So along came ivabradine onto the market. And remember, with no ivabradine on board, her resting heart rate was quite elevated. It would jump up to 180 within 2 minutes with a 2-day headache. As we increased her dose, by the time she was on 5 milligrams twice a day, the heart rate was noticeably lower. Now she could go on the elliptical and her heart rate would still be a bit high, but she didn't get a headache. Her optimal dose was 10 milligrams twice a day, and she would go to 130 beats per minute and could go 40 minutes on the elliptical without a headache. One of the things you'll hear sometimes and read is that if you treat people with POTS and chronic fatigue syndrome with exercise, they'll get better. They just have to get off their lazy bums and get moving. This is a young woman who illustrates that philosophy is completely wrong in most instances. She became an occupational therapist. She works out in Phoenix, and she sent me this slide saying that she made a weekend trip to Sedona and could hike 10 miles in a day. So the people who would say that all you need to do is start people back on an exercise program and they'll be fine and they'll be cured, can't explain this young woman's experience, because even though she's able to hike and she's quite fit now, every summer her insurance denies the ivabradine. She's off it for 2 weeks, and guess what? She gets fatigue, lightheadedness, and brain fog all back again. So she's an example of the fact that you've got to control the circulation better if you're going to get more complete improvements. I'm going to stop there and see what sort of questions people have. Our work has largely been made possible over the years, initially with some grants from the NIH and the CFIDS Association. But we've been able to keep practicing taking care of patients with complex clinical conditions, largely due to philanthropic support. We've got an endowed chair from the Sunshine Natural Wellbeing Foundation. Other families have started endowment accounts. We've had really great colleagues, including Colleen Marden as our research coordinator for many years. 3 years ago, I was able to hire the first nurse for the clinic, Renee Swope, and we worked carefully with Rick Violand and other physical therapist colleagues. We've had some great summer students, and there are too many families that have also contributed to mention everybody, but it has been very gratifying for us to see the big improvements for both people with chronic fatigue syndrome and EDS over the past 30 years as we've worked on these problems. So I'm going to stop there, Kendra, and you probably are seeing the chat room.
Mm-hmm. I'm ready to answer questions. Oops,
all right, do you want to read them out?
Yeah, or if you want to answer the ones in the chat, I have another one that Danielle texted to me. But otherwise, if you can read the questions, you're welcome to just go ahead and answer them. That
Okay.
works. Or I can answer them, ask them for you.
So
Whatever.
one of them is said that the 2020 study found that cerebral blood flow is reduced in ME/CFS patients. How do we treat the reduction in cerebral blood flow? That's a great question, because the cerebral blood flow is reduced probably because there's not enough blood getting back to the heart. So the key is to improve vasoconstriction one way or another. And we often have to go after this with different medications like I showed you, and sometimes looking for what's driving the orthostatic intolerance and the orthostatic pooling. So for example, some people have described the fact that mast cell activation syndrome itself can be the trigger to the reduction in blood flow to the heart and brain. So the optimal way of treating people might be different from one person to the next. There's a question from Megan. Hey, Megan, what about patients that have increased blood pressure on standing or tilt? So that is often seen in people who have what's called the hyperadrenergic form of POTS. I don't like that term, because everybody with orthostatic intolerance in some ways is having excessive release of catecholamines, and they are all hyperadrenergic. But some will get a high blood pressure because there's so much norepinephrine being released that it'll increase blood pressure. You still want to treat them. They may benefit better, more from things like clonidine or beta blockers. And yeah, so that the diagnosis of hyperadrenergic POTS usually requires that people get a norepinephrine level measured during the time they're upright. So that's not done in our tilt lab at Hopkins. It's really done in more experimental circumstances at some of the big autonomic units like at Vanderbilt and Mayo Clinic. Another person has asked, can stimulants and midodrine also be used when patients have a standing increase in blood pressure? Yes, so if they have hyperadrenergic POTS, you have to be a bit careful about that. But if the reason their blood pressure is going up is because they're not getting enough blood flow back to the heart and brain, and you can use the stimulants and midodrine to get them better. We've even had patients in the past who responded when they had hyperadrenergic POTS and elevations in blood pressure, we've treated them with boluses of IV saline, which you'd think would be the last thing you should do if you've got high blood pressure, but that allows their blood pressure to come down because the increase in blood pressure often is a secondary phenomenon. Let's see what's next on the list. Do we find that stimulants can make people feel more anxious? Yeah, that's something you want to watch for. The main side effects of the stimulants can be that they can cause insomnia and keep people up, especially if you take a dose too late in the day. We try and limit the doses to morning or to a short acting form in the late afternoon if people need to finish their homework. But they can make people more anxious, so that's a limitation of the stimulants. And then the other thing they can do, and this can be quite profound in some patients, is they can really interfere with appetite. If they interfere with appetite, we often use an appetite stimulant like cyproheptadine or periactin at bedtime. That helps them get to sleep. It improves their appetite, especially if the stimulant is really helpful for their overall function. And so we don't usually try to chase one drug side effect with another drug, but in that instance, the combination of stimulants and cyproheptadine can be quite helpful. Christine is asking about a teen EDS patient previously had very low blood pressure with POTS and now has high blood pressure. I don't hear a lot about high blood pressure and orthostatic changes in blood pressure. Yeah, we've got a handful of people who have both hypertension and orthostatic intolerance. One of them is the only drug that works for her is fludrocortisone, which helps the kidney hang on to sodium, and it can drive blood pressure up. And we've collaborated with our kidney experts and the hypertension experts in her treatment. There's some antihypertensives that are a little bit better in the setting of POTS, but this girl chose to remain on the Florinef because it was the thing that allowed her to get to college and function normally. Without it, she was pretty non-functional. So sometimes you have to make these compromises, and the patients need to be very involved in that decision-making. Cheryl is asking, are there studies on the dairy protein intolerance? We've published one paper that reports our 31% prevalence of milk protein intolerance in the ME/CFS population. That was published in about 2015. I can send Kendra and Danielle that paper if you want to see a copy of it. Will we be opening to new patients soon? We've often, because we follow people until they're fully better, we've had a backlog for new patient evaluations. We try and get some new patients in all the time, but we've been able to hire 2 new physicians, one a year ago and another one just on the 5th of July. Somebody who had been treating people in the long COVID clinic and herself is hypermobile. So we've got 3 now, and we won't be able to see lots of patients because we try to study people as carefully as we can so that we can contribute to the larger literature. But we will have we have a screening process in place. The patients who are eligible for the current study have to be between 13 and 25. So this is not for the older adults, but that'll be what we're focusing on in the next little while. Let's see. Julia is asking, any evidence of surgery for tethered cord improving autonomic dysfunction? Yeah, I mean, when we have patients who have symptoms of tethered spinal cord where they get bladder dysfunction and sometimes bowel problems, including incontinence of both urine and stool, we screen for that in everyone. And so it's trickier surgery where the outcomes aren't aren't always as positive as we would like them to be. It's a really tough one to treat, but yes, we look carefully for tethered cord, and many patients have improvement in function. So Megan is asking, how does leaning forward reduce heart rate? Well, so if you sit in your chair normally with your feet on the ground, feel how tight your calf muscles are. They're really not doing much. If you move your feet backwards and you lean forward on your legs, your calf muscles are much more contracted and engaged. So it might not necessarily reduce heart rate, but it should improve the blood that's getting back up to the heart. Let's see.
I have a question that Danielle texted me and a few others
Yeah.
that are related to what you've already talked about, Dr. Rowe, if you wouldn't mind.
Yeah, go for it.
All right, back when you mentioned the pelvic venous insufficiency after the pelvic congestion syndrome, and you talked about the symptoms of that and then the stent, could it also be that the leg swelling is not just in the left leg, it could be in both legs, and also just kind of more associated with, I would say, lower abdomen, pelvic, and then top of the thighs? Like,
Yeah. So we've got some patients who have compression of both iliac veins, right and left. Left is more common because of the anatomy, but we've got one EDS patient from Atlanta who's being evaluated for bilateral May-Thurner syndrome. The older teaching on pelvic congestion syndrome was that this is more common in women who've had more than one pregnancy. So probably with the relaxation of the connective tissues that occurs with pregnancy, you're more likely to see the vessels start to dilate. That's the case for varicose veins in the legs, but also within the pelvis. And so pregnancy can be a risk factor, but we've seen it in kids as young as 17, 18 who have massive pelvic venous congestion and have never been pregnant. The other physical finding that is occasionally seen, it was reported more in the past, was that women can have varicose veins in the upper thigh and along the vulva or around the buttocks. So we don't see that in the younger patients, but that has been reported in these pelvic venous insufficiency syndromes.
and I would assume that if you've had treatment for this, not saying who it is, diagnosed way before even EDS and had it treated, but then I guess it could happen again later, even if you have symptoms, that it might be different. I'm specifically talking about the leg swelling, that it might be worth it to have it looked at again, like especially in patients like our population.
Right, and we're having, people are starting to look for greater saphenous vein insufficiency, which is detected by vascular surgeons and causes, some of the increased pooling in the legs. So we're seeing more and more work being done on that, and some people are reporting very nice outcomes if those greater saphenous veins are ablated and taken out of the picture, and patients will have better, certainly less leg pain and often better orthostatic tolerance.
All right. Thank you for answering that. It's very helpful. Another question is, can you speak to or talk about temperature dysregulation fluctuation between cold and hot, especially night sweats that are not related to hormones, and anything we can do to help ourselves?
So temperature dysregulation is really common in EDS, ME/CFS, and orthostatic intolerance. Some of our patients, when they stand, will get hot flashes. We think that's related to their epinephrine levels, and sometimes that will improve if you get them on something that lowers the epinephrine level or its effect, like a beta blocker or clonidine. One of my colleagues at Hopkins, and I didn't talk about this during the talk, is Dr. Malcolm Brock, and he's fascinated by patients who have hyperhidrosis or excessive sweating. And he has identified some new biology behind that, and he directs his treatment against the excessive sweating at blocking sodium channels. We all have sodium channels. Some of his patients have a mutation that allows those channels to have a gain in function, so they are doing more than they should. And his cocktail of medicines that can help with that includes either clonidine or guanfacine, Marinol, which is dronabinol. It's a THC capsule. And that comes from the observation that some patients report that when they smoke marijuana, their sweating normalizes. And hyperhidrosis can be a very disabling symptom. You know, if you need to change your clothes 2 and 3 times in a day, it's not only a bother, but people can have enormous psychosocial kinds of worries that nobody will want to be with them or partner with them. And so Dr. Brock has had a couple of patients who have made suicide attempts because of the severity of their hyperhidrosis. Another drug that he uses for blocking the sodium channels is a urinary drug. I'm blanking on the name of it, but there are a number of things that are available. And we're hopeful because he's now got a mouse model of these sodium channel mutations, and you can test one drug after another to see if it works on improving the function of the sodium channel. So it's a particularly exciting time, I think, for autonomic disorders.
Interesting. So when you're talking back to this temperature dysregulation, specifically if you really hard time at night and it's not hormonal related, is there anything specifically that you found in patients that really helps that?
Yeah, that would be something like clonidine or guanfacine that we would probably try, but also trying to just generally improve the overall circulatory, you know, so, and then things like, you know, some sort of cooling blanket in the bed maybe, but sometimes people just are either too hot or too cold and you're chasing the symptoms.
There's a thing called the bed jet apparently too. That helps. Apparently it's like a cooling thing for just your side of the bed if you have those issues. I don't know if anybody else has found that, but in trying to also help myself, I think it's fascinating.
Yeah, there's another question on here about hypersensitivity to drugs. Is that more common in EDS and orthostatic intolerance? It's certainly more common in people with mast cell activation. And people used to think these people were crazy because they'd come in with a list of 10 or 15 medicines that they reacted to. And they'd say, I'm allergic to these because I feel sick and I get rashes with them, including hives. The allergist would test them for direct allergies based on IgE-mediated mechanisms. And they'd say, well, you're not allergic to any of these. Until somebody finally came up with the idea of incubating these drugs with the person's mast cells and saw that the mast cells went nuts, degranulating and releasing all of their histamine and other products. So the patients were reporting something real. It's just that it was a bit hidden to us why they were having these reactions. And mast cell activation is more common in EDS. We see it increased in people with orthostatic intolerance. So I think that's probably the common factor that leads to more intolerance of specific medications. Also, a lot of the drugs have milk protein in them. So if you've got a bad milk protein intolerance, often the medicines have lactose as a drug, as something that makes the pills stick together, and lactose never appears without also appearing alongside milk protein. So if you're really intolerant of milk protein, you're going to have trouble because of the milk content of the pills. So in that case, we will get people onto compounded medicines that don't have any other food products.
All right. There's another question about livedo reticularis.
So livedo reticularis is a sort of marbly pattern of the skin that we can see. It probably reflects some local autonomic control of circulation, typically in the legs, but sometimes in the arms. We don't treat it differently just because it's there. We try and treat the general circulatory dysfunction and any mast cell component that's there. Somebody's asking, why would a bulging disc resolve the POTS? Well, we don't really know the answer to that. All we know is that it has done so repeatedly. And one of the patients we reported in 2018 had this artificial disc put in. She was off skiing and doing all kinds of things for about 6 years. And then she started getting her POTS and her ME/CFS symptoms back. And we tried all kinds of things to treat her, but eventually got more imaging. And we saw that probably during one of her falls skiing, she had dislodged the artificial disc so that it was now poking onto the spinal cord again. her surgeon, Dr. Edwards at Mercy Hospital, removed that disc, put in a new one, and stabilized things. And she, within 3 months, was back to fully improved. So we've seen this repetitively in individual patients. So not everybody has this, but the ones who do have had some really lovely improvements in overall function. We just need to make sure that they're not, if they're hypermobile, that they're using posture and body mechanics. So they're not turning their neck too far because they can. They're moving their body around so that they're not putting so much strain on the other discs in the cervical spine.
All right, there's a few more questions. Do you want to go ahead and read them? How's your time, Doctor?
I'm good for a couple more minutes.
Okay.
Somebody said their daughter was diagnosed with POTS and seronegative rheumatoid arthritis. Do we see an increase in people with POTS developing autoimmune issues? There's been a lot of interest actually in whether POTS itself is an autoimmune disease, because some people, some groups are finding that if you take serum from patients with POTS and put it into an animal vessel model, that the animal's vessels will react as if they have POTS. There are some autoantibody tests that have been done, typically in Germany, but it doesn't turn out that they really help us yet. It's an active area of interest, and people are wondering whether IV immunoglobulin would treat some of the autoimmune problems. We see a smattering of people with autoimmune thyroid disease. Some people have shown that there's more autoimmune rheumatologic problems like Sjogren's syndrome. We don't have a ton of people with rheumatoid arthritis in our clinic, just a couple. And we find that many people have anti-nuclear antibodies, ANA tests that are positive, but at a very low concentration in the blood. And those patients typically don't go on to get lupus or other autoimmune conditions, but they need to be followed.
How accurate how accurate the laying down MRI is for blood flow, or should they have upright? In terms of when you were talking about the neck and cerebral blood flow.
Yeah, the cerebral blood flow measures are done with the ultrasound technique by my colleagues in the Netherlands. Very few people do that here. So, you can do Dopplers of the carotid arteries, but I think if you did that with the person lying flat, you're not going to pick much up. You really have to be upright on the tilt table. There is a new device that's being tested, which is an in-ear device that measures the external carotid artery blood flow indirectly. We're studying that to see if it correlates with the internal carotid artery flow, so that it becomes a proxy for measuring brain blood flow. But that's in a very preliminary stage right now, so we don't really know if it's going to be accurate yet. Okay. Somebody's asking about a colleague or clinic in Canada that would be comparable. We are not accepting international patients right now. We're actually limiting the people in our study to those who live in Maryland so that we can do telemedicine follow-up visits. But there's a whole network in Canada that I think is called ICANME, that Alan Moreau at Saint Justine in Montreal is heading up, and there are a number of people around the country. One of the most impressive researchers in the autonomic field is Dr. Satish Raj. He's at Calgary. I have a colleague who works at I think at Toronto Women's Hospital, Dr. Louise Neuendorf. Louise is both a pediatrician, and she treats adults as well in her clinic, and she has specialized autonomic training. She's excellent, but I think she's limited her clinic to just 1 day a week. So I'm not sure how easy it would be to get in to see her. Ron Schondorf is in Montreal. There are a lot of people in Canada who should be able to work on this. Another guy at my old medical school at McMaster, who has published on POTS and EDS. So there are a number of folks that you may be able to lean on.
going back to the question about how to test for blood flow and imaging, whether it's laying flat or upright, what is the best way to check then if somebody needs testing?
If they have the reduction in cerebral blood flow,
Yeah,
that's what I was mentioning. You've got to have the Doppler techniques. The transcranial Doppler techniques sometimes can be helpful, but not as much as the Doppler ultrasound.
so not the MRI.
It's not an MRI study, no. Mhm.
Okay. Thank you for clarifying. Thank you.
Yep.
All right. I think there's a few more questions, but I know that you mentioned that you had a few more minutes a few minutes ago. So how are you doing, Dr. Rowe? Are you done?
All right, let's see where we are. Yeah, what about bedbound and housebound patients? That is a very difficult group, not because they're difficult, but they just have so much complexity, and it's very hard to get them out of the house to get testing to figure out what might be behind their symptoms. And we follow several patients who we've done everything we know how to work up, and we have not been successful. One of the venous problems can be stenosis of the internal jugular vein. So you get a bit of narrowing of the blood that's coming out of the brain. That can lead to a backup of pressure that leads to high intracranial pressure. And if your spinal fluid pressure is elevated in the central nervous system, in people with EDS, that can cause a dural tear that leads to low pressure. And so a cycling between high pressure headaches and low pressure headaches, that's really tough to sort out.
Dr. Henderson does a lot of the imaging and testing to look at these different issues, if I'm not mistaken.
Right. We typically do a CT angiogram and venogram of the from the base of the skull down through the neck. And one of the problems can be that you get narrowing of the internal jugular between the styloid process and the lateral aspect of C1. So that sometimes improves with surgery.
Right. Can your body become dependent upon like stimulants if you use it, if they do help? Like if you want to come off, does the body and the autonomic system never find its own homeostasis again?
So we have never seen true, like it's talked about, it's written about that you can get true dependence on the stimulants. I think because they only last for about 12 hours, you're coming off them every single day, or else you wouldn't be able to get to sleep at night. So the phenomenon of physical dependence, like you see with opiates, doesn't seem to occur with the stimulants.
Yeah.
If you feel worse when you come off them, it's probably because they were having a physical effect, not that you were developing dependence.
Right. And in theory, if you go off, eventually your body, or you don't take them anymore, your body will find its own homeostasis again, maybe not as functional as you once were, but not to the point where you can't function.
I mean, you know, the hope is that with treating any of these disorders, we're getting people to the point where they no longer need the medications, but that doesn't happen as much as we would like. And we think some people just need medication support to be functional the rest of their life. Much like if you're hypertensive, you're going to need something to control that once you've developed hypertension. Somebody's asking about getting screened for our study. You can just call our appointment line, and that should be on the web, but it's 410-955-9229. And then they'll send you to our team, and we usually try to get back to people within a couple of weeks, but we only have a small number of people working on the study, so it can be a little bit longer than that. All right, I think I had better get home.
Thank you so much, Dr. Rowe. Thank you for your time. Thank you for answering all the questions for us. Thank you, everybody, for participating. It was wonderful to hear you speak again, Dr. Rowe. Always so helpful. It was great. And if anybody has any last questions, you can email Danielle, and also the information that Dr. Rowe mentioned will be shared.
And I'll send that to you and Danielle when I hang up here now.
Sounds great. Thank you so much. Thank you, everybody.
Thanks, everyone.
Thank you, Dr. Rowe.
My pleasure. Bye.
Have a great day.
Bye.